So, can you see that okay? Right, so I don't know whether you know this, but the Royal College of Paediatrics and Child Health issued new guidelines on what they call perplexing presentations and fabricated or induced illness. The history of this is that it comes from Munchausen syndrome by proxy, which was invented by an English pediatrician some while ago, and I'll come back to him later. So in this guidance, what they propose is that some new definitions of things. They talk about perplexing presentations, which require an active approach by pediatricians, and surprisingly, an early collaborative approach with children and families. That's surprising because I think you'll find in Hull there's a different response taken. One good thing in their rationale for it is that they say the advice of colleagues is always helpful and tertiary specialist opinion may be very helpful. So in other words, they're talking about involving specialists. They weren't originally. When they were doing this guidance, there was rounds of, I think I initially saw it at version 18. I managed to elbow my way into a meeting with government, and there was government and RCPCH who absolutely love me. They've already written to lots of local authorities saying to ignore my research. But basically the government then asked me to meet with them and to give them feedback. Part of my feedback was that they said they want to be collaborative, but not what they were doing wasn't collaborative, and that they had ruled out the idea of using tertiary specialists. So that's come back in. So some of this has changed since the original work. But so the aim of this is early recognition and intervention in order to explore the possible causes of a perplexing presentation. And they're looking to see whether there's some element of exaggeration or fabrication of illness with consequent physical, emotional, social, or educational harm to the child. It's interesting about exaggeration has become effectively part of fabricated illness. I don't know about you, but sometimes when I go to the doctors, I exaggerate my symptoms because I want something to happen. I don't think that's necessarily something that makes me a bad person or whatever. So what does the guidance say? It talks about three issues, and it gives its own really odd definitions of them. Medically unexplained symptoms, perplexing presentations, and fabricated or induced illness. So I'll go through the three definitions. Basically what they're saying is that a medically unexplained symptoms is where the child's symptoms, which often the child complains about and is genuinely experienced, are not fully explained by any known pathology, but with likely underlying factors in the child, usually of a psychosocial nature. And then they add in this bit, and the parents acknowledge this to be the case. So it's only medically unexplained if the parents agree with the medics. If you don't agree, it's not medically unexplained anymore. And then also the health professionals and the parents work collaboratively, to achieve evidence-based therapeutic work in the best interest of the child. That sounds really quite good, but if you happen not to agree with them, you won't work collaboratively. So you stand a chance of being moved into the next category. So why was this term dropped from DSM-5? That's the official look at how we use words and how we define different things in psychiatry. And it was dropped for these reasons. Medical diagnosis does not usually define a disorder simply based on the absence of something. Instead, orders are defined according to the presence of certain positive features. So medically unexplained is a definition by absence. And then the reliability of assessing whether or not there is a medical explanation for somatic symptoms is notoriously poor. Indeed, some medically unexplained symptoms are not so much unexplained or as unexamined. Now, this is the top people in psychiatry saying that a lot of MUS is that we haven't done the necessary work to rule out the medical problems. The next definition they have is perplexing presentation. It's the presence of alerting signs, and I'll come to the alerting signs, when the actual state of the child's physical mental health is not yet clear, but there's no perceived risk of immediate serious harm to the child's physical health or life. So you might think this is just about scratching their heads, but remember, it's also about not whether or not the parent agrees with them. And it's also about the quality of the search for the reason for the symptoms that the child is facing. The reason I say that is because there's a lot of illnesses that are hard to assess, hard to get a diagnosis of. So, for example, Ehlers-Danlos parents can take up to 8 or 9 years to get a diagnosis, and they have to go around lots of people before they get that diagnosis. And similarly with lots of other rare or hard to diagnose illnesses, basically trying to get that diagnosis means you have to do some of the things which they will see as being fabricating illness, or initially, in this case, perplexing presentations. And then the third definition is FII is a clinical situation. Fabricated or induced illness is a clinical situation in which a child is or is very likely to be harmed due to parents' behavior and action, carried out in order to convince doctors that the child's state of physical or mental health or neurodevelopment is impaired, or more impaired than it should be. FII results in emotional and physical abuse and neglect, including iatrogenic harm. That's harm caused by having by medical treatment. So you've got this hierarchy of medically unexplained symptoms, perplexing presentations, and fabricated or induced illness. What's the evidence for this? Well, there isn't any. There is no epidemiological evidence. There was a piece of research done in the 1990s on Munchausen's by proxy, which they say is the same as fabricated and induced illness, but it isn't. And in that epidemiological evidence, they took the basis for saying that somebody had got Munchausen's by proxy was that a paediatrician had referred the child to a child protection conference, to a child protection agency. So that was the basic proof that there was Munchausen's. So it was seriously flawed. And even on that basis, it was a small number in 1 million cases. They've done nothing on the diagnostic tests. So there's no evidence on accuracy or precision of diagnostic tests. So they haven't done anything to say, this is how we diagnose this effectively. They have got diagnostic tests, and I'll come to those next. They haven't done any research on how issues progress. You know, there's an assumption in the report, certainly early versions of it, that people would move from medically unexplained systems into presenting perplexing presentations and then on to fabricating the induced illness. But there's no research done to show that that's the case. They've got nothing to prove that these things are actually connected or even the same things. And they've got no evidence on what they do, the efficacy and safety of therapeutic, rehabilitative and preventive regimes. In other words, they've got nothing on the treatment that they're offering. So there's no evidence on how often it happens. There's no evidence on how to diagnose it. There's no evidence on what's the progression of this, if it is an illness or something that you can diagnose. And there's no evidence on the effectiveness of what they do, but they've still issued national guidance. Here's, originally they didn't say much about their lack of an evidence base, but when I sent in my comments on their guidance, I pointed out all these lacks. So they've now put in their report. We also considered the limited published evidence on prevalence and management of FII. In the absence of published evidence, we relied on extensive consultation and expert consensus from those with extensive clinical experience of managing these conditions. So basically they're saying, we recognize there's no evidence, and we're going to go to people who have been very involved in this. Unfortunately, many of those people are, I find, quite concerning in the way that they work with families. So we've got something that's got no evidence base, but that's got national guidance and that's pushing people to look for it. Is there any evidence, for example, one of the things they say is that there's a high mortality rate, that children die of Munchausen's by proxy. That's not there either. Although the early study looking at this which was done by God, I always forget his name, the paediatrician who was struck off after having invented Munchausen's by proxy, because he gave evidence that led to several people being convicted of murders that they hadn't done. It was later reinstated by the judiciary, although it was always very clear that he'd given evidence that was inaccurate and that it was beyond his ability to give in court. So how do they diagnose it? What they say is there's a set of alerting signs. And these are numerous, and I'm not going to go through these in detail because it would take us hours to do them, but you can see alerting signs in the child, symptoms and signs not observed independently, unusual results of investigations, poor response to treatment, unexplained impairment of daily life. All of these things rely on the basis of them having made an accurate diagnosis. So there's that issue. And they also rely on the fact that that you will get independently observed symptoms. And again, there are real problems with that. For example, many illnesses, there aren't independently observed symptoms. Migraine, there's no way of actually directly observing migraine. It's reported by people. So lots of issues about these alerting signs. And then alerting signs in the parents, their insistence on continued investigations, insistence again on instead of focusing, you've got to agree with them. All of this is about agreeing with them. Repeated reporting of new symptoms, repeated presentations to an attendance at medical settings. Well, if you want to get a proper assessment of children done, and you're struggling to get a diagnosis, you probably will take the child back to lots of different places. Inappropriately seeking multiple medical opinions. Well, that inappropriately is a matter of judgment, isn't it? Providing doctors from abroad, which are in conflict, and the child repeatedly not brought to some appointments. And then lots more. So I'm not going to go through those because I'm going to look at the ones from Hull in a little bit more detail. So, but here are the problems with the alerting signs. There's no evidence base. There are problems with diagnosis, and the World Health Organization is very clear that there are lots of people with rare and hard to diagnose illnesses. It'll affect something like 1 in 8 of all people at some point in their life that they will have a rare or hard to diagnose illness. There's lots of work done on diagnosis that shows that something like 50% of people who go to hospital do not have an accurate diagnosis. Yet this whole monolith is built on the idea that we've got a good diagnosis. Many of the alerting signs will be found where children have undiagnosed illness or unusual presentations of illnesses. And there's no diagnostic test, which means there's a high likelihood of false positives. Well, false positives means people being treated as if they've harmed their children when they haven't. Now, there's been some improvements in what they're saying since earlier versions of this thing. They're saying that the alerting signs that by themselves do not amount to fabrication, but mean there should be further investigation. They say about the tertiary specialist and say that parents have a right to request another opinion, and it's their right to do so. That the alerting signs are not evidence of fabricated and induced illness, and that a single alerting sign by itself is unlikely to indicate possible fabrication. Paediatricians must look at the overall picture, which includes the number and severity of alerting signs. So there's been some rowing back from the earlier versions, but it's still a very concerning piece. What they say the paediatrician should do when they've got these suspicions is to collate all the current medical and health involvement of the child, to ascertain who's given the reported diagnosis and the basis on which they've been done, and to consider whether further investigations or referrals for specialist opinions are warranted or required. So again, there's been a little bit of better work by, they've now said specialist opinions are warranted. In the early versions of this, the experts that they consulted had said that you shouldn't go any further in terms of looking for specialist opinions. I was one of the people who challenged that, and it's changed. So there's been little bits of change, but not enough. So summarizing what's the problem with it, there's a checkered history to this with a serious false accusations. So, you know, Sir Roy Meadows was the person whose name I'd forgotten, who in fact got people accused of having murdered the children wrongly. It treats a multiple of separate issues as if it's all the same thing. Somebody exaggerating a child's illness is not the same as somebody going in and specifically changing medication to harm a child. That it's likely to lead to lots and lots of false positives. I did some statistical work on this, which showed that the number of false positives, even taking the most, giving them the most benefit of the doubt in terms of that, was likely to be at least 10 to 1. In other words, 10 false positives to every one correct diagnosis. There's no evidence base for it all. And there are real concerns about the program of treatment, especially things like structured exercise. So this sounds all very negative, and it is. So let's come to Hull. this is the whole procedure, and it says fabrications or signs and symptoms of past. This is what they're looking for: fabrications of signs and symptoms, including fabrication of past medical history and psychological illness. That's fine, except in the words, what do we mean by fabrication? If they're talking about somebody deliberately changing previous diagnoses, getting into records and making changes, that's clearly a very serious thing, and we should take it very seriously, but incredibly rare. If they're talking about somebody misremembering what the doctor said to them about the diagnosis, or misspeaking about the diagnosis so that they don't say the right medical term, that's not fabrication. That's a sort of mistake any of us can make. Fabrication of signs and symptoms, falsification of hospital charts. I haven't got any problems with that. You know, if people are doing that, then clearly there's a serious issue that needs to be taken. But the next one, exaggeration of symptoms or real problems. Well, who's able to measure an exaggeration? How do you actually know whether this is so my experience of pain and your experience of pain will be very different. Who is it that's exaggerating? Real problems with that as a criteria. Induction of illness by a variety of means, again, no problems with that one. And then obtaining specialist treatments or equipment for children who do not require them. Well, some specialist has given this, if they've done that because of a fabrication of signs and symptoms, which is about changing things, I think there's one thing. But obtaining specialist treatments or equipment for children who don't need them, you can see the problems. And here are the indicators that Hull use. Signs and symptoms are not explained by any medical condition. Well, that means that you've got to have got in the first place. Do not explain reported symptoms and signs. Again, that means that you've got to have got a good diagnosis in the first place. Inexplicably poor response to prescribed medication and other treatment. Well, if the diagnosis is not correct, you're not going to get the right medication or treatment. New symptoms are reported on resolution of previous ones. That's something that often happens in rare and hard to diagnose treatments. Reported symptoms and signs are not observed in the absence of the carer. And again, you know, this is quite often the one that schools don't see a problem with the child, but you're seeing the problem at home. Well, we know that there are lots of situations where that's the case. Hospitals don't see it because they don't have the same level of observation as parents. They can't observe things, so there's clear problems with it. The child's normal activity, child's normal daily life activities, such as attending school, are being curtailed beyond that which might be expected from any known medical disorder. So again, we've already heard about the problems of children who are kept off school because they struggle with it, because maybe they've got autism or some other problem. And the last one is truly laughable: the excessive use of any medical website or alternative opinions. What's an excessive use of a medical website? And whose alternative opinions are we writing off? You know, other doctors, other medics? Real issues with these indicators, which I think we need to raise with Hull. So let's see if there are any hopeful signs. The first is that the NICE guidance on ME challenges the Royal College guidance. So the people with ME have actually taken this through NICE, and they've actually got a challenge to the safeguarding that RCPCH are saying, and I'll show you there what happens there. So one hopeful sign is that that's already there. The RCPCH desperately tried to prevent this guidance going through. You'll have seen newspaper reports about it where they said they wouldn't implement the new NICE guidance, but the NICE guidance has still gone through. So there's a hopeful sign that you can challenge this at a national level through NICE. And if you've got parents of children with ME, it's really important to look at the NICE guidance on that. I've co-written some guidance that the British Association of Social Workers are going to hopefully produce in the next few months. So that gives you two things. It gives you some new guidance, which challenges the RCPCH guidance, but it also gives you a reason to be bringing some of these things up if that comes out in the way it does, the way we wrote it. I'm hoping it will. It's being consulted upon at the moment. You already know about Luke Clements and his work on parent blame, and that's being brought into the national agenda. The chief social worker has started to recognise that. There's a report on the Department of Health website where the adult and the children's chief social worker both say that too many children with autism are being brought into care, and a tendency to use too much of a child protection approach to disability. So there's starting to be recognition at that level. There's the review of children's social care, which gives you some possibilities of challenging this nationally. It's getting into late stages, but there's still things that can be done. And there's an increasing recognition of experts by experience, and the increasing work's being done. So we at PFAN are working with a number of local authorities. We're starting looking at, for example, having a parent advocate who's got lived experience working alongside social workers. Southwark has already appointed, I think, 3, and it's just going up to 8 experts by experience who support parents who are getting involved in child protection investigations. And they've funded the service, though they're not yet paying parents. That's something we're still working on. And there's growing media interest in this issue. At the moment, I'm speaking to about 3 or 4 different journalists, both for the BBC. There's going to be some work done on Panorama soon. So there's a growing interest in challenging this. So it's not all bleak. We can fight it, but we have to do something to fight it. So just so you can see what the NICE guidelines are for ME and CFS, it recognises that those with severe or very severe illness are at risk of their symptoms being confused with signs of abuse. If the person needs a safeguarding assessment, we should directly involve health and social care professionals who have training and experience in ME/CFS. We could fight for that for other disabilities. If a person has confirmed or suspected ME/CFS, needs to be assessed under the Mental Health or Mental Capacity Act, again, social care professionals who have training and experience should be involved as soon as possible. And then this is a big one. Recognize that the following are not necessarily signs of abuse or neglect in children and young people with confirmed or suspected ME/CFS. That the physical symptoms do not fit a commonly recognized illness pattern. So you can see that's a direct contradiction of the guidance in whole, and it's a direct contradiction of the guidance from the RCPCH. That more than one child or family member have ME/CFS, well, that's a different thing. Disagreeing with or declining or withdrawing from any part of their care and support plan, either by them or by their parents or carers, is not a sign of abuse or neglect. in the guidance from the RCPCH, they say that is a sign of abuse or neglect. And reduced or non-attendance at school is not a sign of abuse or neglect. And again, you've seen that that's one of the indicators that they use. The other thing they say is that they should offer children and young people with ME/CFS a review of their care and support plan at least every 6 months and more frequently. So again, what you've got is some really good guidance being put out now by NICE. And that can be used to challenge this stuff on FII. So what can be done? I'm just going to suggest a few things that we could try. Some of this needs to be done nationally. We need to group together nationally to do it. And some of it we can do at regional or local level. So we could follow the example of ME and try and get a challenge into NICE. We can try to influence local response. We can lobby, we can campaign, and we can co-produce services. We can look for opportunities to campaign nationally and locally. Various things come up where you can actually start to do that. Make sure that nothing goes down in the press without somebody writing about it. Make sure that that each of an organisation like yours has somebody who's the press person and is there ready to write when something comes in the Guardian, in the Mail, write and take it on. We can contact the Children's Social Care Review. So we could be taking some of these issues back to it. We've already done that from PFAN, but getting other organisations to do it is really important. We need to start to identify the allies. There are good solicitors out there who can challenge this. There are friendly social workers who can work with your organisation and help you. Not all social workers are taken in by this. And we can join with other parents groups to campaign. And then what you can do locally is you can find out how you're going to support all the other people who are struggling with this. And a key bit of that is to develop an advocacy service. So